Good morning, and thank you for joining us here on the Morning Medical Update. I'm Jessica Lovell. It is summer, and just like many of you, we are working hard to bring you some fun and exciting shows come fall. This morning, we are bringing you a rebroadcast of one of our favorite shows. If you have any questions, please leave them below. We will answer them during our live broadcasts on Monday, Wednesdays, and Fridays. So sit back and enjoy this Best of Morning Medical Update. Good morning. It is Tuesday, September 14th. Welcome into the Morning Medical Update. Coming up this morning, here is the current COVID story. We know that difficulty breathing is a major complication of COVID-19. I can imagine nothing worse than not being able to breathe. We know this can lead to death, and it's something respiratory therapists live with nearly every single day. Many have simply had enough of the death, the heartbreak, and the lack of vaccination. We've had 15 respiratory therapists quit the last 3 weeks alone. These folks have been at it day and night for the last year and a half. So coming up, we are going to hear firsthand from a respiratory therapist and an ICU pharmacist on the COVID response with Delta, because as we also know, Delta is different. But first, Dr. Dana Hawkinson joins us with our numbers. I understand 2 deaths since we saw you last yesterday. We had 6 over the weekend. Not good.
Yeah, I mean, we are still continuing to have deaths. It's very unfortunate. A lot of this is so preventable. We just need to continue to endorse the message of please go get your vaccines. Even if you've had COVID in the past, the recommendation is continue to get vaccination. Vaccination will help your body develop that immune response to all of the variants, and especially any other new variants that we haven't even identified yet. So we know the vaccines continue to work, and they work well in that way in trying to get your immune system to adapt to what they see with the vaccine, but also any possible new variants that are out there. But so far, we are doing much better in the hospital. We have 79 total patients with 38 active patients, 13 of those in the ICU and 7 on the ventilator. We still have 41 in that recovery period. And Hayes has 6 active infections and 8 in that recovery period as well. But overall, I think we're really optimistic and somewhat happy with how the numbers are. We want to keep our fingers crossed and hope that the active infections here in the hospital continue to go down.
And I don't like to be the downer, Dr. Hawkinson, but when we talk about Delta is different, it seems like it's best demonstrated when we talk about this time last year in September, there were 17 deaths. So far here in September, 30 deaths, and we're only halfway through. What does that tell you?
Yeah, I mean, it tells us that this surge was more significant, and we have seen that. We've seen it with these younger populations, these populations that don't have those comorbid conditions. We've talked about it, how our average age of those admitted to the hospital is almost 10 years younger than it was during the previous surges. We've also known how Children's Mercy has talked about the numbers that they have as inpatients as well. So we know that this is affecting more people, more healthy people who otherwise don't have those comorbid conditions. And so that's why it's all the more important to go get vaccinated, to save yourself from even missing work for 10 days because you have the disease, but more importantly, save you from having that higher risk of coming to the hospital and going to the ICU.
Do we have any reporter questions on the line this morning?
Sure. Good morning. Cody Holyoke, KMBC 9 News.
Hey, Cody. Good morning.
Hi. Yesterday, I asked, and Dr. Hawkinson really eloquently responded about the 34-year-old Olathe East coach who died from COVID-19. And for people who didn't or weren't listening yesterday, he wasn't vaccinated, but sadly, his story isn't unique. I'm curious from Dr. Hawkinson and even doctors on the panel, if they want to join in, are you hearing from other physicians, or are you seeing any patients in the last weeks and months changing their minds when it comes to the vaccine, or holdouts coming around, or even family members of patients? I'm curious to see what you guys are experiencing.
You know, I haven't personally seen that. I still have some people in my infectious disease clinic that I see that still don't want to get it. But I know that we have heard those stories from some of my other colleagues who now have come to our vaccine clinic, number one, either because it was now fully approved to get it, but also they've had some instance of tragedy around them, whether it's a family member or a friend or something like that. And it's unfortunate it has to be through those means that their minds are changed or their hearts are changed. But we really need to continue to give that message to promote the science, which it is. These vaccines are extremely well backed by science, by efficacy and safety data. All of those myths, unfortunately, there is that also those good misinformation campaigns that are going on. It is a small minority, but it is a very loud minority. So we need to continue to combat that with the actual facts.
Jace Knudsen is a ICU pharmacist, and we also have Julie Rojas. She works in the ICU, respiratory therapist. I know people are quite advanced by the time they're in the ICU and by the time you see them, but do you hear any stories like that? I think people think that feeling of regret or wishing they would have gotten it, or they were on the fence, but they were just too late. Are you hearing those stories?
Oh, yeah. Back in December, patients would mainly tell me, I wish I didn't have that birthday party, or I didn't wish I had that Christmas party because people got sick. And now I've had patients tell me, I wish I would have gotten that vaccine, or, even asking, can I have that vaccine now? So it really is a game changer.
Jace, you must hear similar stories, I would imagine.
Absolutely. And our nurses at the bedside, all day talk about this consistently, that, patients are remorseful and if families are remorseful, especially those that had unfortunate breakthrough infections and folks that are immunocompromised, et cetera, those that likely transmitted to that person, obviously feel very remorseful and oftentimes, are willing to receive vaccination after, if they ever get well enough to receive vaccination. So it's a really unfortunate and all too common story.
Sure. And Cody, I know you bring up the 34-year-old coach, active guy, loved by all his students, and it just really, I think, hits home for so many people, somebody who just needed a little bit more time to get the vaccine and just didn't in time. So did you have a follow-up question, Cody?
No, you guys covered it. Thank you.
You bet. Okay. So I do have a question from Carolina. She's a reporter over at, I think she's over at Fox 5, Channel 5. Yep. Okay. So why is there conflicting messaging from health professionals when it comes to the booster shots? Dr. Hawkinson, can you answer that?
Yeah. I mean, I think that is, can be a point of trouble for the general public. I mean, we've heard a lot of different messages, and the messages have changed mostly because our knowledge in the science has changed and we've learned more. That is the main impetus for a lot of these messages throughout the pandemic to change. So as we learn more, we understand more. Now, certainly for this, I think the messaging has been more consistent actually with what the CDC or FDA versus the Biden administration. Again, medical science professionals versus the administration. And we know that the group that recommends use of vaccine, the ACIP, which recommends how to use the vaccines, has always been consistent in saying right now there's not enough data to support the use or need of vaccines for those that are not immunocompromised. We know that more information is coming out, but two very good studies in the MMWR, the CDC publication from last week, did show that the vaccines continue to offer very great benefit for those that were vaccinated, even in January, in helping reduce their chance of going to the hospital, going to the ICU, and dying. Now, within the general population, are there certain groups that may need it? For instance, if you are an older age, that may be. But we also have to look at, why are we giving a booster shot? Is it to chase antibody levels and keep antibody levels up, which we know all decrease in time? That's just how our natural immune system works. Or is it really to prevent those more severe cases of disease, and that is going to the hospital, going to the ICU, and dying? And right now, all of our best evidence from many places, not just in the United States, but especially from here, continue to show that the vaccination continues to significantly reduce your risk of going to the hospital, going to the ICU, and dying. So I think we are going to wait. We know that ACIP meets on September 17th. They will review all the data, published and unpublished, and then make recommendations. And we will see and understand, do we need additional dosing for certain populations, whether that is certain age groups above, say, a certain age, either 70 or 75 or something different? or can we all just continue to be fully vaccinated if we have these 2 doses of the mRNA vaccines or that single dose of Johnson & Johnson? So the science and the data continues to evolve, and we'll certainly keep up with that. But I can understand how for most people that would be very conflicting messaging, and it could be very confusing. But right now, I was happy that that opinion piece came out and that review came out in the Lancet saying it's not needed. That would certainly support the published studies that we have here in the United States as well.
Carolina has a follow-up question, too, as well. Will pushback from some health professionals against boosters right now delay boosters for 12 and up becoming available to them? Mm-hmm. Any insight on that?
No, again, I think the best evidence that we have is that if additional dosing is needed, that it's probably going to be in some of those older age groups, and not, especially not those below 65. So I think we're still waiting for that, but I don't think that is going to delay any additional dosing or booster dosing for the other people who are overall 12 and up. I think most people are more concerned with the people that are 12 and younger, and when are those vaccinations going to be available? The best data we have from that is probably later October when that may become available. Again, because the FDA is wanting to be transparent, is wanting to do all the due diligence, making sure that the safety data is there and the efficacy data is there as well.
Any other reporter questions today?
Hi, this is Jody Bertino with KCUR. Piggybacking kind of off the booster shots, the federal government has said that it's ready to offer booster shots to all Americans kind of starting next Monday. You talked a little bit about this. Is that looking like it's going to happen? And is the health system making any preparations?
Well, I think there are several things in play here. One, there is the political and the elected officials on what they want to do. There's also the pure medicine and science. And hopefully they will take cues from the pure medicine and science. But again, we're waiting for ACIP, which is that the Committee on Immunization Practices that directs the CDC and directs people how to use the vaccines. They are meeting on September 17th. So we'll eventually see what they say at that point in time once they've undergone all the data analysis, looking at everything. So we will see. But, the fact of the matter is really anybody can walk into any private pharmacy and ask for dosing at this point in time. Again, we have so much supply here in the United States. There are doses that are going to expiration and not being used every day. I think we would all rather focus on those people who haven't gotten any dosing of vaccine to go out and get those first doses, and then when the time comes, get their second dose as well.
Follow-up question?
Follow-up question. Mm-hmm. We've been hearing from some people that some Johnson County hospitals have either been turning away non-COVID patients or denying them overnight hospital stay because of lack of space. Is this something that you're seeing at the health system, or can you kind of describe why hospitals might be put in this position where they're having to turn away patients?
In unvaccinated, I'm not aware, especially not at our health system. We aren't specifically turning any people away.
Oh, not just non-COVID patients, not unvaccinated. Sorry.
Yeah, I think that has been a concern forever. I'm not sure that necessarily we have ever done that. I've certainly seen stories, and we know that there are other hospitals, especially rural or critical access hospitals, that don't have the capacity to treat normal things rather than COVID, because they are filled with COVID to capacity. I'm not sure that we've really had that problem here in the metro region. You may have a little bit idea on that, a little bit more than I would. But we haven't necessarily, that I understand and know of, had to turn away those patients that are needing critical care or significant evaluation for those kind of routine normal things like heart attack and stroke. But that is always the significant concern. It is probably more of an issue out in the rural areas, but I'm not aware of really necessarily any of that here. Dr. Stites may have more insight to that.
Any other questions? All right, we are going to get to your community questions here in just a few moments. Dr. Hawkinson, really quick though, a couple of questions often come in about your numbers off the top. Do we know if the 2 deaths that we saw yesterday, do we know if they were vaccinated or unvaccinated? Do we get that information?
We do sometimes on once or twice weekly. I don't have that information. We can see if we can get it for tomorrow or Thursday on the recent deaths, but also our current numbers of what has happened recently in the ICU.
Okay.
We do have some numbers as far as fully vaccinated or not in the hospital. I just don't have the numbers of were those deaths, were those people vaccinated. So of our total patients that we have, of the 36, or of the 38 patients that are active, 7 of those are fully vaccinated. So again, that's just around 20% or just under 20%, but we've always stated our fully vaccinated population tends to be a little bit more because of the population that we draw. We do have a lot of immunosuppressed patients, whether that's cancer and chemotherapy patients or solid organ transplant patients or patients who are on immunosuppressives for other reasons, but also some of the transfers that we do get in as well.
All right, thanks for that.
Yep.
Okay, so I want to turn back to our guests, reintroduce respiratory therapist Julie Rojas and ICU pharmacist Jace Knutson. We wanted to start with some of that breaking news that we talked about, that we lost about 15 respiratory therapists due to exhaustion and frustration. Julie, you already have this overwhelming caseload. What has that been like, and how does that change patient care and just your ability to do your job when people are walking off the job?
Well, it affects us so much, and it affects the whole hospital, from the ability for us to discharge the patients quickly, because RTs are the ones that do the study for home oxygen. It also affects our critical patients because you need an RT to travel to IR procedures, CT scans, get those things done in order for us to further your care. And it affects all of us that are still here working, because there's some weeks that I'm here at the hospital more than I'm at home, and your coworkers become like your family, and they understand the things that you see and deal with, and so it's hard for us to lose them emotionally too. When it comes to patient care, I know we're going to be okay, and I know we're still going to see our patients, and I know we're going to give the best care that we can give. It just might take a little bit more time, and in this environment where we are pretty full, you just got to be patient with us.
Yeah, you said it takes more time because you're doing all that work for all those people. Jace, what's it been like? What have you seen just in your colleagues and when you're up on those ICU floors? What's the feeling from those people who are still there and those who probably had enough?
Yeah. I mean, the work feels heavy, right? I mean, as she mentioned, the house has really been full, and so in addition to COVID folks that are staying for long periods of times and have a lot of high acuity and complex medical decisions going on, it really makes for long days. My team is really resilient, and I think we've done a really nice job saying, hey, my load's lighter today, what can I help with, kind of thing. So we've really been kind of picking each other up. But yeah, definitely, the mood feels different this time, right? I mean, especially knowing that there's options out there to limit the amount of folks that are coming into the hospital with severe COVID. And so I think that's really changed the landscape. Early on, around the times that we were getting our first round of vaccination in the healthcare workforce, but it hadn't rolled out to the public yet, it felt different, right? There felt like there was a lot of hope on the horizon here. And I think, seeing where our vaccination rates are and seeing where our hospitalization rates are and the complications and death that are coming with that, it's really frustrating knowing that a lot of this mortality and morbidity is completely preventable.
Yeah, frustrating, disappointing. What makes you both get up every day and come in and keep doing what you're doing? Tell me, what pushes you? What's that fire like?
Just want to see people get better, and I just, I'm here to make people feel better, and we do still have those success stories of liberating people off the ventilator, and it's really rewarding. It's rewarding work.
Show us your shirt. I love this shirt you brought us today. Your lungs.
My lungs.
That's what you're here to get better. I know. But if you would, Julie, just walk us through when you are called in to serve a patient. Tell us what that is like, and what's it been like with COVID, and when you are serving a COVID patient. What's going on, and what are you there to help with?
So the main things that I'm there to help with are a lot of oxygen and also the work of breathing. I go in and I make sure that we're using the best oxygen delivery device for the patient, for their comfort, and just to give them the most oxygen that we can for what they need. Also, we look at their work of breathing, make sure they're not using their neck or their abdomen to help their diaphragm pull up. We have a lot of our patients lay on their stomach, I'm sure you guys have heard, because your lungs are so much longer in the back. So when we put you on your stomach, all the secretions, fluid, gravity helps pull it to the smaller part of the lung, and we can utilize more of the lungs for you. A lot of my job going into the ICU is making sure that these patients are comfortable laying on their face. We got to put pads, and we tape their ET tube and make sure that there's no injury from us laying you down on your stomach.
Yeah, thank you for describing that, because you're there to really help them heal their lungs, correct?
Yes.
Help them heal, let their body heal, because you're going around and talking with physicians about pharmaceutical plans to help them feel better. Tell me a little bit about what you're doing up there in the ICU unit with those COVID patients, and how, and then once they are intubated, what kind of medications are brought in to make them comfortable.
Sure, yeah. I think, just briefly, for those that really aren't kind of familiar with what kind of clinical pharmacy's role is, you probably think more distributional, production, stuff like that, which obviously, is very important, and we'll talk about that a little bit as well. But my role usually is to work very closely with our providers, our nursing colleagues, and oftentimes our respiratory therapists, to make sure that we're using the right meds at the right time and the right way. So some of the stuff that Julie was speaking about is, making sure that patients are getting the maximal benefit from the ventilator. In many times means that we don't want them generating their own effort, and often that can be very difficult, and usually means that we're going to use a lot of pain medications and a lot of sedation medications to try to take them out of the equation and let the vent do more work and limit the amount of damage that patients can actually do to their own lungs by kind of fighting with the ventilator or trying to do more than the ventilator that we want the ventilator to do. And so that's a really complex situation, and getting these folks to a level that's comfortable enough for them to be compliant with the ventilator is oftentimes really challenging, and is dynamic, right? And so that's a couple of the things that we're really working closely with the teams are switching up those medications, and being mindful of potential resource issues, to make sure that we're keeping appropriate supplies of everything that we have on hand, that we're looking out for future patients as well.
So with things changing so quickly, moment to moment, does that affect you as well? Are you constant monitoring to see if there's something that needs to be changed or done differently when it comes to medicating these patients?
Yeah, absolutely. I've commonly said, COVID patients are very slow to recover, but they're very quick to decompensate or worsen at the blink of an eye. And so, urgent and emergent medication use, I would say, is at an all-time high. And when you accompany that with our, unprecedented patient volumes and issues, with supply chain, et cetera, or I would say a dynamic medication supply chain, it really puts a lot of strain on our production, our distribution and acquisition teams. You can imagine what it's like to get all the medications that we need for 800 plus patients in the right place at the right time in a timely fashion. And so, these teams are working, diligently around the clock to make sure we do just that, and we're taking great care of patients. And so, I think just, they're kind of a behind-the-scenes piece to the whole picture, and I think, commonly probably don't get enough credit for what they're doing. And so I think it's important just to take a second to recognize, I think, all of those folks, our pharmacy technicians, their work is absolutely essential, and I don't think that, being behind the scenes, they probably take a step back to recognize the impact of the work that they're doing. But, so I would just, let them know that I see firsthand that they're saving patients every single day.
Well, we see them, we appreciate them, and that's why we love having folks like you on. I know Dr. Hawkinson feels the same way. It's so great to have the faces that I know you're working with Dr. Hawkinson up on the floors and seeing every day. So just thank you for being here and sharing, and just please tell your teams thank you so much for all that they're doing. You talked a little bit, Jace, about supply chain. Anything as we're just in this surge, whether we're coming out of it or not, that concerns you? How how do hospitals like ours and here and across the country, how do they prepare to make sure that there's enough always?
Yeah, that's a really great question. I think especially with such an ever-changing situation, week to week, there might be kind of, maybe new medications on the horizon or things changing day to day in terms of supply chain. The recent natural disasters, I think, have even added an interesting wrench into potential supply chains with the wildfires and hurricane situations, et cetera. It's hard to know, I think, what kind of impact that might have on medication distribution and potentially production, depending on where those medications are being made. And so, navigating real and potential shortages is a really complex situation. We know early in the pandemic we saw a lot of issues with that. We're starting to see, I think, some shortage issues creep up again, not to the extent that we did previously, but there's absolutely no guarantee that we couldn't end up in the same place if the cards aligned, unfortunately.
Sure.
And so, things that we do to try to combat that, we run a lot of utilization reports and a lot of inventory reports to make sure that we're stacking up, meeting needs. And if we're seeing that we're putting a lot of excessive strain on a certain resource, or if we're seeing that supply chain is having issues acquiring those medications, we'll change some of our strategies to make sure that we're conserving or preserving some of those resources for patients that really need it. And so oftentimes we're using multimodal approaches. Traditionally, oftentimes on the ventilator, we're maybe using one pain agent and maybe one sedation agent. Now we might be using 3, 4, 5 at lower doses to try to spread the resources out and make sure that we're preserving all of our potential options down the road.
Couple questions before we get to our community questions today. But, we know COVID patients are in the hospital for quite a long time. In many cases in ICU, Julie, patients often come and go, but with ICU patients, they're there sometimes a long time.
Yeah.
How does that affect you, impact your team?
Well, we really get to know the patient a lot better and their family a lot better, which is nice because, once as they get to that recovery point, the family is allowed to come back into the room and really help with the healing process. It's taken us more from an acute level of care to also kind of a little bit long term and weaning of the ventilator and weaning of the trach. Because once as you're on the ventilator for a couple weeks, we do suggest that you have a artificial airway, and it does help the weaning process of getting these patients off the ventilator, and it makes it more safe, and they can talk on the vent actually with a trach in. So, and they don't have to be on as much sedation either.
Right. So I have to ask you both a question before we get to our community, but it's about just a lot of us who feel helpless, a lot of us regular people. You are all on the front lines doing this every single day, and we're always asking, how can we come together as a community? What can we do? What is your message to all of us today, for those watching and beyond, to know what do you want us to do to help you help patients?
I just would like people to be kind to each other. We're all trying our best out there to do what's best for our community and our family and keep people safe. And just to listen to the experts and take their advice and not take your own data and turn it into COVID being a farce, that it doesn't exist, because it really does exist. And I do feel like a lot of the healthcare community is feeling the burnout and feeling the pressure because people don't think it's real, and it is very real. And the simplest things like wearing a mask and washing your hands and not coughing on each other, it can help a lot. And right now, the biggest thing that most of us want is just for everyone wants life to get back to normal. And we just want everyone to be healthy and not have to be in these walls for weeks on end. This younger population, I see a lot of them, they're younger than me, and it breaks my heart. And I feel like everyone thinks when it comes to healthcare that it's not going to happen to them and that they're invincible until it does happen to them. And COVID has no boundaries, and we don't know why some people react the way that they do, especially when it comes to their respiratory, their lungs. Some people don't have a problem with it. Other people, it's detrimental. So just be kind to each other and listen and be compassionate and work together instead of fight.
I have to ask you this question as if you and I were having a private conversation. I'm just compelled to ask you, what is it like to lose a patient and to have to talk to their family? What is that like for you, and how do you come out of that?
It's difficult. It stays with you. You know, now in this surge, we do allow patients' family members to come and see them if we know we're going that route. But back in the winter, family members couldn't come up, and so it would just be me and a nurse in there, and we would have the family on an iPad, and I would be holding the patient's hand till the very end so that someone was in there with them. And it stays with you watching that, and just to know right now that we could possibly prevent that just from a shot is what really, I think, affects a lot of us emotionally.
If they could only see what you see every day, right?
Yeah.
Jace, what can you add to that?
Yeah, no, I completely agree with all that, and really, my recommendation would really be simple. That, you know, our best path forward is really increasing our vaccination rates. So, you know, if you've decided not to pursue vaccination previously, we would really ask that you'd reconsider or look for credible resources to help you make that decision. You know, be mindful of where you go. Mask in public, especially indoors. If you don't feel well, stay home or get tested. You know, these basic principles, I think, really can help limit the spread. You know, and I think in general, if increasing vaccination improves bed availability for folks that are seeking our care for non-COVID related reasons, right? I mean, I know that Dr. Williamson had been on here previously talking about, you know, how many folks we've had to turn away from our walls when knowing that they needed our help, and that's a really tough pill to swallow. And I think, you know, a lot of this preventable hospitalization is limiting our ability to take care of other patients. So I think that's a really important piece of you know, owning a sense of community. I think, you know, take care of yourself, but take care of your friends and family. Take care of your community. And I think right now, getting vaccinated is the right way to do that.
Thank you both for that. We're going to get to some community questions, and we're getting some political kind of charged questions today. So guess who I'm going to leave those for? Dr. Stites tomorrow. I'll let Dr. Stites navigate those. He knows how
much
to.
appreciated.
As we said, right? I know we're getting some of those a little feisty. So I'm going to skip over those, but I hear them, I see them, and I will pass them along, and we will try to get to those in the next couple of days. But here's one from Susan. Is the makeup of the booster the same as the original, Dr. Hawkins? And we've gotten that before, but clear that up.
Yes, it is. It's just an additional dose. At this point in time, it's just an additional dose of the same one that was used in the primary series.
Okay, so Isaac says, I heard recently of a hospital in New York State where enough people quit because of not wanting the vaccine. So much so that they had to stop certain procedures. Do you see any signs of that here or any Kansas City hospitals? I mean, maybe everybody can kind of jump in on that one, because you've seen people walk off, and how might that affect other people in our community?
I mean, most of the people that I work with are for the vaccine. So thankfully, I don't really have those conversations with healthcare workers that don't want it. But I see it kind of as in like fighting what you do for a living. Like, what we do for a living is you know, everyone wants to trust us when it comes to being on that ventilator, proning you, giving you all sorts of medication. Trust this too. You trust us with your life when you come in here, but you don't trust us when we tell you this is safe.
Dr. Hawkinson, would you give your kids shots right here on this program like you did a year ago or months back if it was not safe for them?
No, I would not. And I've said this before, I'm absolutely thankful my kids were of the age to be able to get vaccinated. And I love that first answer we had about trust. It's so important. You know, you have to trust something. You know, you have to understand, and I guess people are picking what they choose to trust, but there are so many people out there who are trying to give that message that these vaccines are safe. They are efficacious. They will significantly reduce your chance of coming here and having to go on the vent and being part of those stories that we've just heard here today.
So Dan has a question, just double checking, because you have been vaccinated, can you not pick up virus and pass it on to unvaccinated kids, like unvaccinated kids under the age of 12?
So I think there's a lot of questions in this question. So what we initially believed was that your ability to transmit the virus after getting vaccinated was significantly reduced. There is some question about that now, but we still believe that there is a significant reduction in your ability to transmit the virus, either over the time frame or just because of the viral replication. But we know that you can still replicate a good amount of virus, but your ability to transmit is still significantly reduced. This is supported by a couple of good studies that looked at communities with vaccination, but also household with vaccination. And those communities and those household that had high vaccination rates, that did seem to be less of a transmission to those susceptible populations, especially those children.
So kind of on that same note, what can vaccinated people do who live in the same home with unvaccinated children? I'm one of those people. Yeah. Neither of my kids are vaccinated yet. This person says, I would think to wear a mask, clean door handles, open windows, air cleaners, filters, all those things, any of those things? Yeah,
I mean, I think you have to understand what is your family dynamic. It is hard to be around those people that you love, especially your children, doing masking and doing those things indoors. But take that knowledge that in those households that they did see vaccinated persons, their attack rates in those households, those secondary infections, were less than in those households where there were not vaccinated people. So I think just understand that, and then if you want to take further precautions by quarantining or isolating away from other people who are unvaccinated, if you've had exposure or you have the infection, that's a reasonable thing to do as well.
Catherine wants to know, you mentioned the ACIP committee earlier. Do you know if the committee will be discussing the final approval of the Moderna vaccine?
So ACIP makes recommendations on how to use the vaccines. The final approval, I believe, will come through the FDA once the FDA gets all of the data and analyzes all of that data.
Okay, so Chelsea has a question, and she is when I say she's speaking your language, she is. I don't know if I know what all this means.
Lots of words.
Just a lot of big words. I'm not good with the big words. Okay, so Chelsea says, this is for. She says she works at a critical access facility, and we are trying every form of oxygen, high flow, NIV, before deciding to intubate a patient. What are you guys allowing in vitals? SpO2, RR, ABG? Before you are making decisions to intubate? Is it still recommended as a last-ditch effort? Goes on to say, due to studies we are seeing with mortality and mechanical ventilation, our facility is waiting as long as they can, especially with difficulty in transferring patients to higher level care.
Yeah, so it really depends on the physician, and it depends on the patient's wishes on what we are doing. So we will use our Airvo, which is our heated high flow cannula, 60 liters, 100%, sometimes having to put a non-rebreather on top of that. And we typically like to see those patients 88% and above. I have had one rare one that was like 82% and above. Really what drives it is the work of breathing. If this person's breathing like 40 times a minute, they are sweating, they look like they can't even talk to you, that's when we go more towards the ventilator. I do feel as if the BiPAP kind of just is this hybrid mode that we just kind of get stuck in, and it kind of just elongates, whereas if we intubate them, we can start proning, because it's hard to prone on a BiPAP. It's that pressurized mask that has tubing.
And tell people what proning means. The regular
laying on
people
your stomach.
Out there.
Laying on your stomach.
When we see you flipping people over is proning. Okay.
So, and there's been some studies that staying on the BiPAP long time with COVID, it makes the inflammation worse, because you're just pushing that air down there. And also those patients, they still have to eat, they still have to drink, and it causes more potential for aspiration when it's just pushing air in like that. So I feel like, at least at our hospital, we do go more towards intubating before sitting on a BiPAP forever, because that BiPAP does lead to more complications and also like skin injuries because the mask is so tight on them as well. And I feel like once as we get them intubated, we can, let them relax and heal the lungs.
That all sounds bad.
It does.
How can we prevent that?
You know.
Vaccinated.
I think I know the answer to that one. Okay. Okay, so I'm going to ask this last question. We may have time for more. It really speaks to, and this is Mary Ann's question, but a lot of people just, that concerning feeling for people when people in the medical field are not recommending the vaccine or not getting the vaccine. It seems reasonable, though, for people to think, like you said, this is what we do for a living, so we are going to promote it. But Mary Ann says that she spoke with a friend in California who has neuropathy. Her doctor is not vaccinated, does not want her to be vaccinated. Just wanted to know what you all think about that. Jace, I'll let you get us started.
I mean, obviously there is going to be a minority there that chooses to go aside from the science, right? I think it's disheartening. I think it does send, mixed signals and mixed messages when we're really kind of trying to promote, mass vaccination and trying to limit hospitalizations, et cetera. I think in many ways that's a step back. I think it's unfortunate. I would say, from my experience, that's been more rare than not from a provider or from a healthcare worker standpoint. I think in general our message has been pretty consistent, but I think you're going to find some of those. And again, I think if you're seeing providers that are not recommending vaccination, I think asking for a second opinion or asking for rational explanation as to why that is really important.
Dr. Hawkinson always, that's his get a new doctor answer.
It's time to see a new provider, but I think to Jace's point, it's a thoughtful point. Asking them why and understanding that is certainly something you could do as well. But overall, again, vaccination continues to be recommended for nearly everybody 12 and over. There are very, very few exceptions to not getting it.
Well, and I like what you said. It is the minority of people because it goes back to the trust we've talked about. You want to trust what your doctor is saying. You go to trust them. And it makes me sad to think that someone's sitting in someone's office and hearing the message, don't get vaccinated.
I deal with, in my personal life, nurses that don't agree with masking. My Board of Education has a nurse on it that is very strongly against kids wearing masks at school, and that parents should have the right to sign medical forms. And it's really difficult.
Are those parents doctors?
No.
Okay.
No.
We just have to clear that one up.
So it's really hard, too, in the medical field when you're seeing people speak out against the science. And it's frustrating.
That you try so hard to educate on. So.
Yeah, I think that's a good point. There are these opinions and mandates and rules and restrictions going on about either not getting vaccinated or masking, and I think we should be clear that these are based on non-medical reasons. All of the medical data support the use of masking and distancing. All of the medical data support the use of vaccines. So it is very important to understand that we are certainly staying in our lane with the medical and the science and the data issues, and the data is overwhelmingly supportive of masking in those high-risk situations, of continuing to distance, and of course of getting vaccination.
Melanie, thank you so much for your comment, because this is the perfect one to end today's program on. Melanie says, one of the hardest parts of this pandemic is the feeling now that we as physicians are being vilified for simply wanting to limit suffering and death in this pandemic. As a community physician, I just want to thank your guests and your daily physicians and all that you all are doing. We see you and are proud of you, and we stand alongside you. Thank you to all your staff, nurses, RTs, PTs, OTs, clergy, and anyone else I'm forgetting, not just here at the health system, across our community. People are showing you the love. I hope you're feeling it.
Thank you.
Yeah,
we appreciate you too.
Well, we really appreciate you.
Yes.
And you guys are welcome back anytime. Thank you so much for being here and just sharing your story and your insight. I want to just go around and get some final thoughts. Jace, just what do you want us to know?
I think actually piggybacking off that last comment, I think what I would say is, when you present to us with an acute infection, our best intervention is already past us, right? So I think, ask yourself, if you come to the hospital, would you want all of our kind of more experimental therapies? Really what we're seeing in a lot of these studies with the agents that we're using is we're trying to maybe move the needle by a few percentage points, right? 3%, 5%, 6, 7, 8, maybe 10% if it's something that has really shown good promise. For these medications that also carry a lot greater risk. And so if you're interested in getting those things, then I think you really need to step back and say, why am I not vaccinated? Because the data is so much stronger for it. The safety and efficacy data is outstanding, and the latest CDC data suggests that it will reduce hospitalization by at least tenfold. We're not talking about moving the needle by a few percentage points, at least tenfold. And then of those patients that get hospitalized, at least another tenfold of those are going to be reduced mortality. And so when you're talking about bang for your buck, vaccination really makes the most sense.
I love that passion. All right, Julie, final thought from you.
I'm just piggybacking off you. I mean, I can't do any more perfect than that. So,
well, we thank you so much for being here. Come back anytime. Dr. Hawkinson, can you follow that?
Yeah, I mean, I can still echo everything that was said. I think it was great. I thank our guests for being here. We've heard great stories about what happens up on the floor when you are the last person who is trying to give oxygen relief and breathing relief to that person. And just understanding that there are people who continue to be here every day to try and make you or your loved ones feel better, but also understanding that a lot of this could have been prevented. And so really, hopefully nobody has to undergo that tragedy and that suffering because we know there are preventable means of getting to avoid that, and that is through vaccination. So continue to endorse that message of getting vaccinated. Encourage your friends and loved ones who have not yet been vaccinated to get vaccinated.
Well, we appreciate all three of you every day, and thank you so much for being with us today. Tomorrow we are back with another episode. Dr. Stites is here. Open mics with Dr. Stites. Yes. All right, so we know that most private insurers are now no longer waiving cost sharing for COVID-19 treatment. So what does that mean? We get this question a lot. So join us tomorrow morning starting at 8 o'clock as we break down the changes in insurance for COVID patients. Have a great Tuesday. We'll see you back here right at 8 a.m.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcasts. Now everywhere podcasts are available.
Thank you so much for joining us this morning for this Best of Morning Medical Update. You can catch our live broadcasts every Monday, Wednesday, and Friday. And don't forget, you can always email us at medicalnewsnetwork@kumc.edu or reach out to us on Facebook, Twitter, and YouTube. We will be back to our live shows 5 days a week starting September 6th. So please go out, make it a great day.